Welcome to The Explainer. Today, we're telling the story of some incredible medical progress. Really, it's about how a debilitating condition went from being treated just based on tradition to being managed with cutting edge, patient focused science. It's a powerful look at how asking the right questions can change absolutely everything. And it all starts with this number. We're talking over 1 million people around the world every single year affected by something called malignant pleural effusion, or MPE. Now, this is a complication of advanced cancer that makes one of our most basic functions, just breathing, incredibly difficult.
So to picture it, imagine your lung is a balloon inside a box. MPE is kind of like that box slowly filling up with water. It crushes the balloon, leaving no room for air. The breathlessness is severe, and the main goal of any treatment is really simple. You've got to relieve that suffocating pressure.
To really get how far we've come, we first need to look at how this condition was managed for decades. And it was an approach based, well, more on habit than on hard evidence. This quote from our source material really just nails the problem. For the longest time, doctors were doing what they'd always done. But then, a new generation of researchers started asking this really crucial question: can we do better for these patients? And that question, that's where our story really begins. This is the point where rigorous clinical trials started to challenge those old ways of thinking, building an entirely new foundation for care, piece by piece, trial by trial. So think of this timeline as our roadmap for this explainer. It charts over a decade of landmark studies, from the early trials in 2012 that first started poking holes in the old methods, all the way to 2024, with trials that are confirming new quality of life outcomes. Together, these studies completely reshaped how MPE is treated. The first questions weren't even about a total revolution. It was more of an evolution. Researchers just wanted to optimize the standard procedure you get in the hospital, which is called talc pleurodesis. That's where they use a sterile talc powder to help the lung stick to the chest wall so fluid can't build up again. The Time 1 trial is a perfect example of this. It asked simple but really important questions, like, does the size of the chest tube actually matter? And the finding? Oh yeah, it did. Bigger tubes worked better. It was a small change, but it made a real difference in how well the procedure worked. And this spirit of just making things better continued. In 2020, the TOPS trial took on another long-standing debate. Was a more complicated keyhole surgery any better than a simple chest tube? The answer was a clear no. They were pretty much equally effective. And that was a huge finding, as it gave hospitals and patients much more practical, flexible options. But here's the thing. Just tweaking the old way wasn't enough. The real game changer, the true revolution, came with the new device, the indwelling pleural catheter, or IPC. And this marked a critical shift in thinking. The focus started to move away from just what happens inside the hospital and towards the patient's quality of life outside of it. And this just illustrates the difference perfectly. The old way meant being a passive patient stuck in a hospital bed for days. But the IPC, well, it allowed care to move from the hospital right into the home. It empowered patients to become active participants in managing their own symptoms and, crucially, avoiding those long hospital stays. And a trio of major trials really cemented this new approach. First, Time 2 back in 2012 showed IPCs were just as good at relieving breathlessness. Then Ample 1 proved they dramatically cut down on hospital time. And just recently, in 2024, Optimum confirms that the quality of life outcomes were comparable. The evidence was just undeniable. This was a powerful new first-line alternative. Okay, so once the IPC was proven to be this fantastic option, the next logical step for researchers was pretty obvious. Figure out how to use this new tool in the absolute best way possible. And a key question came up right away. Should patients drain the fluid from the catheter only when they feel breathless, or should they be doing it on a fixed, regular schedule? Now, this is where it gets really interesting. The results from trials like Amplitude were, frankly, stunning. Draining the fluid every day more than doubled the chance of the lung healing itself, a process we call spontaneous pleurodesis. And this meant the catheter could potentially be removed for good. This discovery led to another brilliant idea. People started thinking, wait a minute, what if you could do the highly effective talc procedure, which normally means a hospital stay, through the convenient outpatient IPC the patient already has at home? And the IPC Plus trial in 2018 proved that yes, you absolutely could. This created this powerful new hybrid option, which meant care could be personalized for patients who wanted the convenience of being at home, but also wanted the highest possible chance of a permanent fix. But at the same time, researchers didn't forget about the hospital-based procedure. They kept finding ways to improve it for patients who needed it. And this time, they turned to technology. The simple trial in 2022 was just so clever. It showed that by using bedside ultrasound to literally see if the procedure was working, to check if the lung was sticking back to the chest wall, doctors could take out the chest tubes way, way faster. This simple use of technology cut the median hospital stay from 3 days down to just 2. Now, progress in science isn't just about finding what works. It's also about proving, with certainty, what doesn't. And believe me, that knowledge is just as powerful. So you have trials like Time3, which tested a clot-buster drug, and Swift, which tested a special silver-coated catheter. They both came back with clear no answers. And this is incredibly valuable. It prevents everyone from adopting ineffective or expensive treatments, which protects patients and saves precious healthcare resources. So, what's the big takeaway here? The crucial point is this. In just 1 decade, the entire landscape of MPLEA care was transformed. We moved from a single, rigid, tradition-based approach to a flexible menu of evidence-based options, all centered on the patient's actual needs and preferences. You know, this story is about so much more than just a medical breakthrough for one condition. It is a powerful case study in what happens when dedicated, patient-centered research, one clinical trial at a time, asks the right questions. It really does build a better, more humane future for everyone.